May I invite Dr. Ashwani Mehta. He's at the M Cardiology and Senior Consultant Cardiologist from Sir Gangaram Hospital, New Delhi. He will be talking on, particularly focusing on heart failure. We know in the last decade we have great advances in the management of heart failure, including ARNIs and SGLT2 inhibitors. So his talk will be on empowering heart failure care with SGLT2 inhibition. When, how, and why. Dr. Ashwani Mehta, please.
Thank you for the kind introduction, respected chairpersons and friends. Today we are here for this interesting meeting, which is SPEEDCON, and we know that now cardiology and diabetes, they go hand in hand. There's a lot of common soil hypothesis, and today I'm going to talk about how empowering the heart failure care with SGLT2 inhibition can bring about differences in the life of our patients, whether with diabetes or even sometimes without diabetes. So we know whenever we are looking at any patient of diabetes, any patients with multiple risk factors, the challenge today is that most of the patients with diabetes, if we look, there are two major drivers. One of the very big drivers is heart failure, and another being the ASCVD. Now, this is a very interesting slide, and it looks at contextualizing the risk among patients of heart failure. So not just they have high risk, but we can really look at these patients who have established heart failure, so they would be having risk of so many other issues. I'll not like to go in great detail, but what I like to tell you and show here is that any patients of heart failure, what we see that if any patient has any time, any admission in their lifetime, so what happens to them is that they can have a rapid decline. And this is something very interesting in patients of heart failure. Whenever they get admitted, their lifestyle, their whole life expectancy, their outcomes, they get a dip. And with each admission, there is reduction in the cardiac function. And not just that, ultimately they die. So what are we trying to look? Why I'm showing this slide? Because this is something which is very important. And that is the reason in all heart failure studies, the heart failure admissions have been brought into focus. So if we have to target one thing which can prevent this decline, is to prevent the admissions for heart failure. If you do that, probably you're looking at the better outcomes of our patients. So we have some Indian data also. So I'm going to talk about this Kerala acute heart failure registry. Now this is a very interesting registry, and what it showed was that patients with heart failure, so if they are treated and if we look at their outcomes, we still do not have most of our patients on guideline directed medical therapies. So you see the difference that whether it's reduced ejection fraction, whether it's the mid-range ejection fraction, or whether it's the preserved ejection fraction, whatever. If the patients are on guideline directed medical therapies, the outcomes are different. And if they are not, the outcomes are different. So why I'm showing this? Because it's very important to have good guideline directed medical therapy. And we have evidence from EMPA-REG trial, huge trial. Also we have evidence both in reduced ejection fraction and in preserved ejection fraction and in the mid-range, that if we treat these patients with SGLT2 inhibitors, right there in the beginning, the outcomes improve. I need not go into great details that how it works well. Still, we are learning more and more. But definitely, there's a lot of role of free water clearance, and not just that, a direct effect on myocardium. Number of studies have shown mechanistic benefits coming as early as 12 weeks post treating them with empagliflozin. Then we also have the afterload reduction, we have neurohormonal stimulation and also changes in the autonomic balance. And what it does is the improved cardiac structure and function. And I'm sure you all must be aware that there's just a few days back, we also have evidence in acute heart failure that how it improves the quality of life. You can't really map these patients in a short span looking at the outcomes. You need a long-term study, but in the short term, the studies have shown great benefit even in that. So just to put it straight, what SGLT2 inhibitors do, what empagliflozin does, is it reduces the overall cardiac hard endpoints. And what are those? Worsening heart failure, cardiogenic shock, or sudden cardiac death. And it reduces significantly. Here I like to make one very interesting point. There is nothing known as a stable heart failure. Many times, patients of NYHA class 2 and 3, when they have heart failure, and you'll be surprised that the incidence of sudden cardiac death in NYHA class 2 and 3, which you and me see every day in our clinics, coming and walking in and walking out, the incidence over a 5-year period is not less, it's up to the tune of 20%. And here you have a drug which reduces that. So that's a great benefit in addition to what we already know. Just to recapitulate the Emperor Reduce study, so it was done in patients with heart failure, and I had the privilege of being one of the principal investigators, and we looked at the outcomes irrespective of diabetes. And what we did, patients were on guideline directed medical therapy, and on top of that they were given either empagliflozin and placebo, and we looked at the primary outcome of cardiovascular death or hospitalization for heart failure. And I just showed you the rationale, the basis that why cardiologists, why heart failure physicians are obsessed with hospitalization for heart failure, because that predicts the outcome. And also we looked at the secondary outcomes, and for the first time tried to look at the kidney function decline. And if you look here, this is a very interesting finding which has been summarized. There was a hazard ratio reduction to 0.75 for CV death or heart failure hospitalization, and then again heart failure admissions, the hospitalizations reduced, hazard ratio was 0.7, and something which is again of great concern to all of us sitting here. Despite advances with the RAS blockers, whether it is ACE, ARBs, so on and so forth, all these patients continue to have a steady decline in their eGFRs. Even if we treat them optimally, even with ACE, ARB or with ARNI, the heart failure patients continue to have a decline in their eGFR, and for the first time it showed benefits coming, and the p-value was significant. It stabilizes the renal dysfunction, and that is the benefit. Not just that, so it looked at in HFrEF the risk reduction for mortality or worsening, and it starts right in the beginning. The curves start to diverge just at day 12. So the benefit starts to occur much early. This is irrespective whether the patient has diabetes. This is irrespective whether the age is more than 65, less than 65, whether the patient is on MRA, without MRA, patient is on ARNI, without ARNI. So this one drug works in all scenarios. Now this is something very interesting, and there were questions raised that what about the safety outcomes in patients with and without diabetes? Is it different? So I do find a little bit of difference in our country. And if you look at our usage of SGLT2 inhibitors, it is largely inhibited because of risk of genital infections. It's not urinary tract infection per se, but the genital infections. But in the trials, if you look here, there was no great difference, and the incidence is much less. It's not even 2%. And the hypoglycemic events again, if you look. So whether the patient was diabetic, non-diabetic, it was all the same, and again it is quite a very safe drug. Similar trial, the Emperor Preserved study. Again, similar benefits. Reduction in all the endpoints were seen and consistent benefits observed. They started appearing at day 18 and they all showed great benefits. Again, in Preserved, it worked irrespective of male or female, diabetes or non-diabetic, if the EGFR was more than 60 or less than 60, or if the history of atrial fibrillation was present or not present. So this again is a big pointer that this particular drug is a potent heart failure drug cutting across all subgroups of patients. Similarly, no unexpected safety outcomes. There have been concerns initially with the ketoacidosis. Probably people got confused. Ketonemia, what they found in the blood, initial reports with empagliflozin, if you look good 7-8 years back, people were talking of ketoacidosis, but it was not really ketoacidosis. Ketone bodies were present in the blood or in the urine. It doesn't really mean it's ketoacidosis, it's just a ketotic state probably. But no real ketoacidosis, no hypoglycemic effects, no great change in urinary tract or genital infections. But genital infections, we know, are more. We also know in our country, the incidence, I think, is much more than what is reported in the trials. And to the tune of, I think, approximately 5 to 10%. And we need to be careful. If we teach our patients how to use it and be a little careful, we can take care of that. So consistent benefits, whether it's HFrEF, mid-range or preserved ejection fraction, and this cuts across all the classes of heart failure. Now this is something interesting I was talking about, referring to a very, very recent study, the Impulse study, which looked at patients in acute heart failure, and they included patients who were having acute heart failure, and the patients at the inclusion had to have systolic blood pressure more than 100. They were stabilized in the sense they did not require any increase in diuretic dose, no IV dilators, no inotropic agents for 24 hours. So critically sick patients, but still on the verge of stabilized, they were given empagliflozin right in the beginning. And what it showed was reduction in all-cause mortality, reduction in heart failure events. So it works not just in the setting of chronic heart failure, but even in patients with acute heart failure. And similarly, the safety profile is quite good, whether it's the adverse events, whether it's the hepatic injury, whether it's the acute renal failure, which has also been a little concern, whether it's been volume depletion, hypoglycemia, or any other. So today, if we have to treat heart failure, we treat them with all the 4 drugs, ARNI, beta blockers, MRA or SGLT2. ARNI can be substituted with ACE inhibitor. And the paradigm has shifted if you look here. We start now much early. We need not wait for a couple of months or post-discharge. And even days 7 to 14, you can start these patients post-discharge, all these drugs. And the beauty is this drug doesn't need to be up titrated, doesn't need to be changed. A single dose once a day, just fire and forget, and it works so well. So that's why the guidelines have changed. The guidelines do recommend, all the major guidelines, whether it's the ACC/AHA guidelines, so they have included now for both mid-range ejection fraction heart failure and also heart failure for preserved ejection fraction. So if I have to say, what do the guidelines say? I would say very simple, the sequencing and the guideline directed medical therapy dosing clearly indicates to start using these drugs right up front. Don't wait for patient to deteriorate. Use it right in the beginning. It doesn't change your blood pressure. Much easier to tolerate. No electrolyte disturbances. You can give other drugs also along with it. No problem. So one of the first drugs to be given and very well proven on all accounts, whether it's trials, whether it is your personal experience, or whether it's the guidelines. So this is something new which is coming about, known as a rapid sequencing algorithm. Interesting. I'll tell you why it's interesting. It is changing the paradigm over its head. So one of the first drug to be used in heart failure, if you see here, is beta blocker plus SGLT2 inhibitor. Why beta blocker? So we are always worried of sudden cardiac death. It takes care of death. And why SGLT2 inhibitor? When you give this, you do not cause fall in blood pressure. You do not destabilize the patient. You do not cause electrolyte disturbances. And then consider adding ARNI. And then later on, once the patient is stabilized, start considering use of MRAs. So this is something interesting. This is a food for thought. And this has been proposed by Milton Packer and McMurray, who happen to be one of the authorities in heart failure internationally. So it's simple. One single dose, once daily, no titration, and works all along. So just to summarize, we know SGLT2 inhibition has got a proven benefits, more so in HFrEF, but all across the spectrum. Early onset of cardiovascular risk reduction is of prime importance, and especially today in this conference where most of the people are looking at managing diabetes, we know we can't improve outcomes without cardiovascular risk reduction. And one of the drugs to use it, much less safety concerns, less monitoring needs, synergistic effects with other cardiovascular therapies. So how does it work? It has got various salutary effects on pathological pathways, multiple ways it works. Volume and pressure offloading, beneficial effects via the renocardiac axis, improved cellular metabolism, and another interesting thing, when to use. This is something I'd like to emphasize. Don't wait for your patient to get sick. Use it in the beginning as a foundational therapy. At the time of hospital discharge, if patient is clinically stable, even in patients with mild CKD, you can use even if the EGFR is more than 20 to 30. Safe to use. In fact, these are the patients who are going to benefit a lot. Remember, it's a first-line drug in patients with ASCVD and diabetes. Thank you so much for your kind attention.
Can I ask one question?
Yes, sure, please.
You see, as you have tabulated the drugs for CHF, all these 4 drugs, ARNI, beta blockers, MRAs, and SGLT2 inhibitors. You let us assume that the use of diuretics is going to be eliminated.
Diuretics are one of the most important drugs. Diuretics have been shown in trials to reduce the morbidity and mortality, both mortality also, but little overused. So the guidelines say that if your patient is having features of volume overload, you use diuretics irrespective of these drugs. The problem is that when we start diuretics, we continue it indefinitely. So that idea of continuing it indefinitely needs to be taken care of. That needs to be done away with. And probably most of our heart failure patients, they would still require some amount of diuretics. Still, it does not form one of the foundational therapy. It's one of the add-on. You need to increase it if the patient is in volume overload, otherwise you can get away with it.
Sir, usage of MRA and ARNI together.
Yeah.
How frequently do you come across hyperkalemia and you need to discontinue the treatment?
Yeah. No, this is something.
I feel this is quite frequent.
Yes,
So
this is
more
very,
monitoring is important.
Yeah, this is a very important question. Now, I'll tell you how the trials are done. One of the very big trial was the Paradigm Heart Failure trial. And I was privileged to be one of the investigators for that also. So that drug looked at using ACE inhibitor, which was the enalapril. Why enalapril? Because worldwide enalapril is the drug for heart failure. Ramipril in India is very popular. but worldwide it's enalapril. All major trials done with enalapril. Ramipril is post myocardial infarction. So on one arm they give enalapril plus MRA, and in the other arm they give ANI plus MRA. And if you look at the outcomes clearly showed that the incidence of hyperkalemia was there in both arms, but much less with ARNI compared to the enalapril. Similarly, decline in renal functions much more with enalapril compared to the ARNI. This still is a bugbear of cardiologists, hyperkalemia, especially in patients with diabetes. And that is the reason there are new drugs coming, there are potassium binders coming, available internationally. Big trials have been done, and they are giving these potassium binders along with these drugs and further reducing the incidence of hyperkalemia significantly. So that's a very good question, but very nicely taken care of.
Thank you.
Thank you, sir.